In this second and final video of the lower extremity, we're going to go over fibular head mechanics, the arches of the foot, and some final counterstrain points of the lower extremity. In order to talk about the fibular head, we first have to talk about the motions of the foot. So we're going to start off there. So foot motions. Just like you could supinate and pronate your hand, you can also supinate and pronate your foot. So for pronation, if we want to do that with our foot, we're going to have to go into dorsiflexion, eversion, abduction, abduction. So what do those motions do? They take the foot a little bit further away from midline. So remember, dorsiflexion is when you bring your toes upward. Eversion is when you tilt your foot outward, away from the body. And abduction is when you take it further away. So that is going to be pronation. When you make that motion with your foot, other bony landmarks are also going to move to accommodate. So some motion is going to be in the talus and also in the tibia. When you pronate your foot, your talus and your tibia are going to accommodate by externally rotating. Your talus will also accommodate by moving posteriorly. So that's pronation. Let's move into supination. Remember, supination for your upper extremity is when you kind of turn your hand as if you're trying to hold a bowl of soup. It's the same idea for your feet as well. So imagine you're trying to hold a bowl of soup with your feet. For supination, it's going to be the opposite of pronation. So you're going to plantar flex, invert your foot, and adduct your foot, adduction. Remember that plantar flexion is when you point your toes down, inversion is when you tilt your foot inward, and adduction is when you bring it closer to the midline. So if you do that with both of your feet, you might have a better chance holding a bowl of soup. When you do this, your talus and your tibia are going to accommodate this motion. It's going to be in the opposite direction. So talus and tibia will internally rotate, and your talus will move anteriorly. So now that you understand the motions of the foot, we can now move into fibular head mechanics. Now the fibular head is going to be one of the main topics of this lecture. So you need to know the motions of the foot in order to understand the motions of the fibular head. So when you have your foot in neutral, the fibular head will also be in neutral. It'll be running parallel with the tibia. When you dorsiflex your foot, your fibular head is going to move. So when I dorsiflex, the fibular head will move anterior, and the distal portion of the fibula will move posterior. So when you dorsiflex, you're going to have an anterior fibular head. It's going to be the opposite when you plantar flex. Your fibular head is going to go in the other direction. So when you plantar flex, the distal portion of your fibula will move anterior, and your fibular head will move posterior. So when you plantar flex, your fibular head will move posteriorly. P. So what are you going to see in a patient that has some sort of fibular head dysfunction? They'll potentially have some decreased range of motion in their ankle. Which is because the fibular head is not moving properly. This lack of movement is going to cause a lack of accommodation for ankle motion into supination and pronation. What you can also see is pain in the ankle region, but also pain in the knee region. So if you have a patient who comes in with ankle pain and knee pain, you can potentially think of the fibula as being dysfunctional. Even if they come in with simply knee pain, you can still think of the fibula. So how do we make the diagnosis? You're going to do what's called the spring test. You're going to have the patient sitting on the edge of the examination table. You're going to pinch the fibular head bilaterally, and then you are going to spring the fibular head anteriorly and posteriorly. When you're doing this, you're going to assess for range of motion on both sides. And whichever side doesn't want to move furthest into one direction, then that's how you're going to know which side is dysfunctional and how to name it. Remember, you always name a dysfunction by what it can do. So if on the right side you're doing the spring test, it goes easily into the anterior motion, but it doesn't really like to go posterior compared to the other side. That means that you have a right anterior fibular head. So to get the diagnosis, you do the spring test. So how are we going to treat this dysfunction? We're going to use muscle energy. So remember back all the way at the beginning when we're talking about how you do muscle energy. You passively move the patient into the restrictive barrier, then you have the patient isometrically contract into the freedom, or what they can do, which is also the name of the diagnosis. So we're going to use that in order to set up the treatment. So let's say that we have an anterior fibular head first. So if you have an anterior fibular head, that means that the foot is more than likely in some sort of dorsiflexion. If it's in dorsiflexion, that means that your foot is pronated. So this is the freedom. This is what the foot can do. If you're going to put it into the barrier, that means that you're going to put it into supination. So to achieve the barrier for this treatment, you put the foot into supination. So then what motion do we instruct the patient to move into for their isometric force? Move into the freedom. So what can they do? They can dorsiflex because you have an anterior head dysfunction. So you put them into pronation. So you remember all the steps. You need to have them do this 3 times, move further into the barrier, then at the end bring them passively back to neutral, and then you rescreen. It's going to be the exact opposite for the other dysfunction. So if you have a posterior fibular head, you're going to engage the restrictive barrier, posterior fibular head, plantar flexion. It likes to go into supination. The barrier is pronation. So pronation barrier, and move into the freedom, which is the diagnosis, which is plantar flexion. Do the treatment, bring them passively back to neutral, rescreen. So now we're going to transition to a topic that still comes up on exams, but is kind of more anatomy based. But we can talk about it in the OMM sense if you can think about manipulating where exactly the bones are by pushing them. So we're going to talk about the arches of the foot. Now we came up with an advanced organizer for this. It's going to be Tetris pieces. So you're going to see what I mean as I'm drawing this out. There are 3 different arches that we need to talk about: the transverse, the medial, and the lateral. So we'll start out with transverse. And we'll draw our Tetris piece. So in the Tetris piece, we're going to have 3 bones: navicular, cuneiforms, and the cuboid. These 3 bones are going to make up your transverse arch. So the next 2 arches are your medial and lateral. So these 2 arches have the exact same Tetris piece as a transverse arch. So we'll start with that. Navicular, cuneiforms, and the cuboid. So the transverse arch has the entire Tetris piece. It has the navicular, the cuneiforms, and the cuboid. The medial and lateral arches share the Tetris piece. So the medial arch has a navicular and the cuneiforms, while the lateral arch has the cuboid. Because they share the Tetris piece, we're going to add in some extra bones. Each arch is going to get some of the metatarsals and 1 additional bone. So the medial arch is going to have metatarsals 1 through 3, and the talus. While the lateral arch is going to have metatarsals 4 through 5 and the calcaneus. So going over it again, transverse arch, the entire Tetris piece. Medial and lateral arches share the Tetris piece, while they both have some extra metatarsals and 1 extra bone of the foot. So now we're going to finish the lecture with some counterstrain. But to talk about that, we're going to go over some of the ligaments of the ankle. So this is going to be your fibula. This is going to be your talus. And this will be your calcaneus. So imagine that the toes are this way, so we'll draw in some extra toes going this way. So there are 3 ligaments that we need to go over. We have the anterior talofibular, the calcaneofibular, and the posterior talofibular. So the name of the ligament gives away where it's located. Anterior talofibular is on the anterior side, connects the talus to the fibula. Posterior, the same reason. Calcaneofibular, exact same. The reason that I point these out is so that you can know where the attachment and the origin of the ligaments are. So this is the final time that we have any counterstrain points. Moment of silence for counterstrain points. So counterstrain is an indirect technique. You bring the 2 ends closer together to make it do what it can do. So you're already going to beat me to this. How are we going to do counter strain? So these ligaments are all on the lateral side of the foot. So if we're going to treat the lateral ankle and we need to bring the two ends closer together, we're going to evert the foot. Now imagine that we're on the medial side of the ankle. You have some different ligaments and different muscles that attach in that area as well. Don't worry about the names, but since they all attach in the same area, you're just going to bring the two ends together. And to do that, you're going to invert. And then one final one, plantar fascia. So a common thing that you'll see on the exams is an individual has lower foot pain when they wake up in the morning. It takes them a little while to stretch out. They can feel it right on the bottom of their foot or closer to their calcaneus. They're trying to point you toward plantar fasciitis. So how are you going to treat it with counter strain? Bring the two ends closer together. So you're going to flex the foot and collapse it, and then add some compression to try and bring the two ends of the plantar fascia closer together. So for plantar fascia, you will flex and compress the foot. So this was our final lecture on lower extremity. We went over the motions of the foot and how to relate that to the fibular head mechanics. We went over the arches of the foot and used our Tetris piece example. And we also talked about the ankle, the ligaments, and our final discussion on counter strain. And that's lower extremity, part 2.